Okay, so I might pace around a little bit. I think hopefully you can still hear me. I have this like ridiculous podcasting microphone that I accidentally got when we started teaching online with the pandemic. I thought I was ordering like a golf ball size mic for my department, but it's enormous and makes me look like a weird podcasting bro. But it should work for this, I think. Hopefully you can hear me wherever I am. So I guess I'll just jump into this. Now, this isn't going to be a traditional philosophy talk. I don't really have an argument that I'm going to make here. Instead, I'm going to walk you through a kind of workshop that I've been developing and have piloted a couple times where I teach phenomenological concepts to clinicians. It's designed primarily for nurses, but we've taught it to clinicians in other areas as well, so psychiatrists, and also lots of rehabilitation therapists, occupational therapists, physiotherapists, respiratory therapists. So what I'm going to do first is talk about how this project came to be, starting off with a project on phenomenology's applications in qualitative research, especially qualitative health research, and then explain how the approach that we're developing for using phenomenology or integrating phenomenology with qualitative health research ended up being an approach that also worked really well for integrating phenomenology with approaches in clinical practice. So within qualitative research, if you read a handbook on qualitative research methods, they'll usually introduce you to say 4 or 5 different approaches or methods. And typically at least one of those approaches is going to be a phenomenological approach. And when you read through these texts, they often refer back to people like Edmund Husserl, Martin Heidegger, maybe also Maurice Merleau-Ponty or Jean-Paul Sartre, although Husserl and Heidegger are the big ones. And they claim some kind of roots in philosophical phenomenology, although of course the kind of aims and approaches of the qualitative methods will be somewhat different than the philosophical methods. But for the most part, when you look at these approaches, and there's not just one approach, it's not a kind of monolithic approach, there's not just one way of doing phenomenological qualitative research. There are a number of different methodologists and theorists who have developed phenomenological approaches. But typically, what they do is they draw on the phenomenological methods, right? The philosophical methods of phenomenology. And they figure out ways to use those methods or adaptations of those methods for their own empirical qualitative research. Now, the main ones you'll see are the epoche or the reductions. And the way that they tend to characterize this is to say that a Husserlian epoche or reduction is used to bracket or suspend one's biases or prejudices about a subject matter or about the topic of your research. And that puts you in a better position to investigate the topic. But there are a couple of problems with this, and this is something that Dan Zahavi's been writing about. So this project I'm talking about here is one that's done in collaboration with Dan Zahavi, and the initial workshops we developed, we designed together along with other collaborators external to the project. And Zahavi has recently argued that a lot of these methodologists, the approaches they're taking from philosophical phenomenology aren't actually doing what they think they do. So he's argued that they've misinterpreted the role of things like the epoche or reduction in Husserl's project, and that actually what they're doing with it in qualitative research is something fundamentally different. So there are these kind of broad interpretive problems, but I think the more important problem that Zahavi also points to is that the aims of philosophical phenomenology just differ in some fundamental respects from the aims of empirical qualitative research. And there's no reason to assume then that methods that were designed for achieving the aims of philosophical phenomenology are also going to work for achieving the aims of empirical qualitative research. Now, once you get to this point, once you make this kind of critique, one conclusion you might come to is that we should just kind of divorce phenomenology from qualitative research and they should go their separate ways. But that's not the conclusion that we come to here. Instead, we argue that there are still really valuable resources from philosophical phenomenology that qualitative researchers and especially qualitative health researchers can use. But they're not the resources that they've typically been using, right? They're not the methods of philosophical phenomenology. So what we've done instead is turn to other successful approaches to applied phenomenology outside of philosophy, especially approaches that are used within psychiatry and in the cognitive sciences. So if you look to these approaches, typically what psychiatrists and cognitive scientists have done when they use phenomenology in their own research is they don't take phenomenology's methods. Instead, they take core concepts from phenomenology. And the kind of concepts I'm thinking about here are what lots of phenomenologists will refer to as things like essential structures or ontological structures of consciousness or of experience or of existence. It includes things like selfhood, embodiment, temporality, empathy, affectivity. So each of those concepts is something that's received considerable attention by philosophical phenomenologists. They've articulated all of these concepts in considerable detail. And what you see psychiatrists and cognitive scientists doing in many cases is taking those concepts and using them in some way to frame or orient their empirical study. So one really good example of this is how phenomenological psychiatrists have studied schizophrenia. And many phenomenological psychiatrists argue that schizophrenia should be understood as a kind of self-disorder. But in order to understand what they mean by that, we need to distinguish among, for instance, different levels of selfhood, right? Basic or minimal selfhood distinguished from narrative selfhood. We also need to understand lots of different structural components of selfhood, like senses of agency as opposed to senses of ownership. And once you have a fairly kind of robust understanding of the structure of selfhood as developed by phenomenologists or as articulated by phenomenologists, then you can also understand how that structure of selfhood might become altered or disturbed or disordered in a variety of conditions. So in this kind of research, right, the psychiatrists are often going to use methods that are already used within their field, right? They're not drawing methods from the philosophical project of phenomenology. Rather, they use their own methods, which might be, for instance, certain kinds of diagnostic interview techniques, but those methods are going to be facilitated or framed through these phenomenological concepts. So the conclusion that we've come to is that you can do the same kind of thing in qualitative research and qualitative health research. You can use philosophical concepts and take these concepts as a frame or as a guide, and then you would use them to, for instance, generate an initial research question and generate a series of interview questions that you would use to answer that research question. You might also use them to frame the way in which you analyze your data after you've conducted your interviews. So there are a variety of ways in which you can do this, but the general idea here is that you shouldn't worry about phenomenology's methods. Those are philosophical methods, and while they might, in some cases, have a role to play in empirical research, they often don't. And instead, what we should really focus on, the real value that phenomenology provides to these kinds of empirical approaches, whether it be psychiatry, cognitive science, or qualitative health research. The real value from phenomenology comes from these kind of core concepts. It's account of the core structural features of experience. So what we started doing is running workshops that were initially for qualitative health researchers or for students who wanted to do qualitative health research. So for instance, students in nursing and other healthcare professions. And we would introduce them to some of these problems, right? Zahavi would go over these, his critiques of these other approaches, more traditional approaches to using phenomenology in qualitative research. And then we'd also introduce things like concepts of embodiment or concepts of empathy, and give the participants in these workshops an opportunity to think about how they would use those concepts to frame and conduct a qualitative research study. Now, one thing I noticed when doing these workshops, and keep in mind that a lot of the people in these workshops weren't just researchers, a lot of them were also practicing clinicians, is that once you introduce these kinds of concepts, for instance, the concept of embodiment, they were often able to start thinking about concrete interactions they've had with patients in a new way. They're able to reflect on their own experience in a new way and these individual interactions they've had with patients in a new way, even before they've done any kind of qualitative research using these concepts. So it seemed like while the concepts, of course, do have value for a new approach to doing qualitative health research, they also have a kind of immediate clinical value or practical value. And you might be able to teach them to practicing clinicians who are not academics, who don't do any research, and they might still be able to get a lot of value out of understanding these concepts and using these concepts to reflect upon their own experience and the experience of their patients and their interactions with patients. So from there, I went on and developed or designed a pilot workshop that I've run a couple times, about a year ago. And these workshops were primarily designed for non-academic clinicians. Again, initially designed for nurses, but I've also run them for physicians and rehabilitation therapists and hospital administrators and so on. So they have a pretty wide scope. Now, I'll run you through how I've kind of structured these workshops and how I've motivated them, because there are a few challenges I ran into in the process. So first of all, it might seem like if you're going to introduce phenomenological concepts to clinicians who don't have a background in philosophy, you might think that the best way to introduce them is the same way that you'd introduce students in, say, an introduction to philosophy course, right? Other people who don't have a background in philosophy. But I found that that's actually not the best way to go about this, that the structure of motivation needs to be different. So within philosophy, whenever we introduce some kind of new philosophical approach or we introduce a new philosophical theory or concept, we typically introduce it and motivate it by framing it within the phenomenological canon, right? By introducing it as a response to some earlier debate or some earlier philosophical problem. So even an introduction to philosophy course, if you were, for instance, going to talk about the phenomenological concept of embodiment in an intro to philosophy course, you would often set it up as a response to a Cartesian view of embodiment, right? So you might say, well, Descartes has a view of the body as fundamentally distinct from the mind. There's two different kinds of substances. And once you have this kind of dualistic view of the relation between body and mind, then you end up with all of these kind of interesting philosophical problems, understanding how they are related, how one can interact with the other, how the mind can control the body, how the body can send information back to the mind. And you end up with all of these philosophical problems. And then you can say, well, there's this alternative view of the embodiment and the body that comes from phenomenology, from Husserl, from Merleau-Ponty, and so on. And on this view, it doesn't really make any sense to even think about a disembodied subject, right? Subjectivity is irreducibly embodied. And once you start from this position, you might end up with new philosophical problems, but you're not going to have the old philosophical problems. So you kind of motivate it in that way by situating it within the history of philosophy. Now, the problem with this is that most of these clinicians in the workshops aren't really going to care what Descartes thinks about the body, and I don't think they should care that much about what Descartes thinks about the body. So instead of motivating it by framing it within this philosophical discussion or philosophical debate, I tend to motivate these concepts or their interest in these concepts by finding some kind of direct clinical application from the start. So before I've even described the phenomenological concept of embodiment, I might start off with a general question like this and ask, how do people experience their own bodies in the wake of acute or chronic illness? And then there's a variety of sub-questions that you might use in order to kind of fill this out. And when I provide these sub-questions, I mean, which ones I use will depend on the audience and the kind of workshop model. But typically I draw questions from contemporary phenomenological studies in the phenomenology of medicine or phenomenology of illness and point to the specific philosophers who are asking these kinds of questions so that they can see a direct clinical relevance between philosophy and their practice. So drawing on the work of Javi Carroll, for instance, we might ask, what is it like to lose faith in your body when you have a respiratory disorder? Drawing on the work of Jenny Slatman, we can ask, how do women respond to scars after breast surgery? Drawing on the work of Drew Leader or S.K. Toombs, we can ask, how do patients experience their own bodies when examined by a healthcare professional? Now, when I introduce these questions at the start of the workshop, everyone in that room will have some sense of what this question is asking, and they might even have an initial sense of how they would want to answer this question. But one thing I can stress from the start is that while you can, of course, have an initial understanding of these questions, an initial sense of how you might want to answer them, by the end of the workshop, once you have a much richer view of the phenomenological account of embodiment, you will hopefully understand these questions in a different way, and you'll be able to provide kind of more nuanced or concrete answers to these questions, or at least be in the kind of position you need to be in to have a discussion with a patient where you could get the information you'd need in order to answer these questions in the right way, or in ways that are kind of more illuminating for understanding patient experience. So we have some kind of initial link now between philosophy and clinical practice, but we also understand that that link can be strengthened throughout the course of the workshop as you develop a more familiarity with these kinds of concepts. So, actual structure for the workshop, I then jump into the concept and articulate at least a few basic features of it, right? So the workshop model that I've run is on embodiment, just because that's an issue that will apply broadly to almost any illness. You could, of course, run workshops on temporality or empathy or affectivity or whatever it happens to be. But one thing to keep in mind here is that for each of these concepts, you could easily have I dropped off, I think.
Yeah, you're back. Okay. Are you now no longer co-host? No, you are co-host. Okay, so you should be able to share your screen again.
Where did I drop? Or how long ago did I drop?
Just like a couple of seconds. So you were pretty much where you were.
Okay.
Thanks, Anthony.
No problem. Okay, you can see the screen again?
Yeah, we can see it.
Okay. So as phenomenological concepts, you could of course devote an entire semester-long course or module to it. So there's only so much you can introduce in the space of something like a workshop like this. Typically, these workshops, I would do like a half-day workshop, right? A 2-hour workshop, followed by an hour of breakout sessions, for instance. So you do have to kind of narrow down just how much you're going to be able to introduce here. But for instance, when talking about embodiment, I would start off with the distinction between the lived body and the corporeal body, talk about how the body as lived is something that's absent or transparent. It's pre-reflective. It's a medium of experience, right? It's something we experience through rather than something we have an experience of. And then immediately contrast that with the corporeal body, right? The body as it becomes opaque, it becomes an object of reflection or an object of experience. And once I've taken a few minutes to introduce the basics of this concept and this kind of conceptual distinction, I'll then step back and give the participants some time to talk about it themselves. So I would not recommend running like a full 2-hour lecture style workshop. Instead, I think that no matter how good you are at kind of communicating these kinds of concepts in clear and accessible ways, they are still abstract concepts. And I think the best way to introduce them is to give the audience a lot of time to kind of fill them out with their own examples. And usually when they give examples, you're able to kind of push them a little bit and get them to analyze these examples a little more carefully using these concepts. And as long as you do this kind of publicly in front of all the other participants, you can establish a kind of situation where they'll slowly develop a stronger understanding of the concept through their individual applications. So what I'll often do is, depending on the size of the workshop, I might pair people up or put them into small groups or give them a chance to just a few minutes to write something in response to a question I have for them. And I'll ask them to think first usually about their own experiences rather than the experience of their patients, right? Everyone has experienced some form of illness. So it's not too difficult to get them to zero in on this. And I'll ask them, for instance, to think about a case in which they experience their own body as an object and to try to use the concept I've just introduced to elaborate a bit on what that experience was like. And then, they'll start sharing these experiences, and through that sharing of experience, we can fill out the concept in a bit more detail. So after kind of back and forth like this, I usually talk for maybe about 20, 30 minutes at most, and then have 5 to 10 minutes in this kind of discussion and go back and forth with a 2-hour session. Then I like to have breakout sessions at the end. Depends on the size of the workshop. I've run, for instance, one workshop with about 15 people that didn't have breakout sessions. We just transitioned to that same kind of model with the same 15 people. In other cases, I've run this workshop for 100 participants. And in that case, we broke them into 3 breakout groups. But in order to do that, I had to, of course, have people who were trained in philosophical phenomenology who were able to facilitate the 2 other groups. So luckily I had that for that workshop, but there's a lot that you can kind of change in this model. So I'll show you a few of the questions I use for the breakout sessions, because rather than using breakout sessions just for kind of open discussion and reflection, I wanted them to be fairly structured. So I typically use 3 fairly long questions and then break up the breakout session into those 3 sections. So the first question I've often asked is, think of a time when you experienced your own body as an object. Was there a specific event that triggered this experience? Was the experience effectively charged? For example, did it involve feelings of shame, pride, embarrassment, and so on? Using some of the concepts introduced in the presentation, try to describe this experience in detail. And again, you might want to let them talk amongst themselves or give them a few minutes to write something down first before they share. And ideally, once they start sharing, you'll want to use this opportunity to facilitate their understanding of the concept while also exploring the specific examples that they give. And usually after they've had some chance to reflect on their own experiences, I'll then ask them to start reflecting on patient experience. So you can ask things like this. If you have provided healthcare for patients or clients, try to identify 2 cases in which your patients experience their own body as an object. One case should be a harmful experience of objectification, and one should be a beneficial experience of objectification. How did the situation differ between these two cases? What contributed to the experience being beneficial or harmful? And do you think that you played a role in how your patient experienced their own body? And if so, how? And of course, you can also run these workshops with a mix of patients and clinicians. In some workshops, I've had patient advocates or patient representatives, but that was kind of the minority, right? There were just a few of them out of, say, 100 participants. But usually I've oriented these workshops toward practicing clinicians rather than toward patients. But of course, you could restructure it in a variety of ways if you wanted to run it for patients. And then I'd often end with a prompt that gets them to start thinking a bit more about how they might take what I've just introduced and use it in clinical practice. So you can use a prompt like this, drawing on some of the concepts introduced in the presentation, try to formulate a few phenomenologically inspired questions that you might ask patients. These questions should help you and the patient better understand their bodily experience of illness or how their healthcare treatment shapes their bodily experience. And often at this point, they start to really think much more carefully about how they would put this into practice and how it would facilitate communication between themselves and their patients. So finally, I want to think about what we expect people to take away from these workshops. So within philosophy, and maybe academia in general, when we give a presentation, we usually have a really clear idea of what we want the audience to take away. Right? We have one particular conclusion we want to come to, and we want to convince the audience of the legitimacy of that conclusion. I don't think that's a good way to think about these workshops. Despite the fact that there are plenty of ways to bridge philosophy and clinical practice, and you and the participants will of course come much closer over the course of this kind of workshop, there's still a pretty huge gulf. And right, me having no clinical experience, there's a sense in which I just can't really anticipate all of the directions in which the participants are going to take the concepts that I'm introducing. So I think one important thing is just to acknowledge that some of the participants are going to take away something different than what you expected. And I would kind of say that you probably shouldn't have overly narrow aims. Right? You can have some sense of what you'd like them to take away, but also expect that that's not what most of them will take away. And again, remember that these concepts are extremely difficult to convey, and we do often use weeks of a semester or an entire semester to kind of articulate one of these concepts in considerable detail. You can only do so much in a kind of 2-hour session. I haven't yet moved on to a model where we do follow-up workshops, although some people have expressed interest in doing this, so we might be able to do that at some point. But in that case, I'm not even sure that I would want to do workshops on the same concept. It might be worth doing like a workshop on embodiment, followed a few weeks later by a workshop on temporality and so on. So there's lots of different ways to structure this. It's very kind of modular. But I think those are the main points I wanted to hit on. So if you're interested in this, the project is still ongoing. We're now doing data collection to figure out what the impact of the project was and the impact of these workshops is on clinical practice and on education. So there are a few of the articles related to the project there if you want to take a look at them. That first one is the one where I articulate the concept of embodiment as I use it in these workshops and talk a bit about the structure of the workshops. But like I said, the project is ongoing. If you're interested in participating in one of these workshops later or want to host one, either in an academic setting or in a clinical setting, feel free to get in touch and we can figure something out. Or if you're interested in trying to run one of these kinds of workshops yourself, I'm also happy to talk about that. Thank you.
Thank you so much, Anthony. That was really, really interesting. So I think I'm just gonna hand straight over to Sam, and then we'll do Q&A and things like that at the end. So the second speaker that we have today is Samantha Gallivan. So she is an orthopedic surgeon with St. George's Hospital, and she's also deputy academic lead for collaborative projects at Imperial College London. And her research focuses on understanding tacit and embodied knowing in the expert practice of surgeons, stone carvers, and sculptors. And she will be giving a talk today entitled Using Phenomenologically Informed Qualitative Methods to Explore Surgical Practice. So we're very glad to have you here today, Sam, and I'll hand over to you.
We're getting there.
Okay.
My computer's slightly grumbling at being asked to share. It doesn't.
I see.
How's that going? Is that better?
That's perfect. That looks great. Yeah.
Fantastic.
Brilliant.
Right. So this is going to be a little different, and I'm afraid to say it's a little different from the advertised title, but we will get to the research at the end. It's very interesting to me to get to speak to a very interesting group of people whose background is slightly different. I'm going to introduce myself and explain what I do at the moment. So as Harriet said, I'm an orthopaedic surgeon. That's my clinical training. I finished my surgical training in 2016. But my other job is that I work in curriculum review and course design. And it's very interesting to me to listen, especially when we had the conference, some of the ideas that people had about the role of philosophy in the undergraduate curriculum. And as someone who designs courses for a living, those conversations were particularly interesting. And then the third part of what I do, which is oddly and in a way that I never expected in the middle of my career, I'm actually doing more research than ever. And as someone with an academic background in education, I research surgical practice as well. So I've had a very strange, circuitous route to get to come and speak to people like you. So it's really kind to be asked. In the online format, I kind of agree with Anthony that it's really hard to give a paper. So I've sort of cut this into two halves. And the first half is to speak from the perspective of someone who's an educator. And the second half is to look at what phenomenologically informed qualitative methods in medical education might be. So the question was asked, should we and how do we integrate philosophy into the undergraduate medical curriculum? And I don't think there's an easy answer to it. There would be a lot of resistance, and there is a lot of resistance. But just to give you a flavour of what happens on our side when we do curriculum redesign as clinicians, you sort of sit everyone in a room and ask, what are the hallmarks of your course? You know, what's the overarching mission? How do you describe yourselves? At Imperial, we always say that it's producing the clinician scientists of the future. And of course, that's interesting in itself because that mission statement is written by a room of clinician scientists. So obviously it reflects on the people who are in the room and reflects why we should have a diversity of people in the room. Otherwise, all they're going to do is create images of themselves. And we often say we imagine the day one graduate. So what knowledge, what skills, what attitudes do we think people should embody on the first day of practice so they're ready to be doctors? Now that is pretty easy to measure. You have examinations, you have finals examinations, but the second part is really much more difficult. It's about how do you support doctors in the whole trajectory of their career? How do you ensure that the habits of thought and action that they have support flourishing, support an attitude towards being inquisitive and kind and empathetic, and that's really difficult to track. And also when you redesign the curriculum, when you ask what you want to include, it's really a speculative act because you're asking people to think about what they think medicine will be in the future. So to give you an idea of time frame, one of my colleagues designed the course 25 years ago that I sat in the late 90s. And so that will probably affect my practice for another 30 years. Why do I mention all these things? Well, because if we are going to talk about integrating philosophy into the undergraduate curriculum, we've got to think about the people that we've got to persuade. And decisions about curricula are anchored. We have GMC guidance and standards. All medical schools in the UK have the new medical licensing exam coming up that they're thinking about. And they are like turning oil tankers. They are huge groups of organisations of people, all of with their own territories. It's very difficult to put things in. Why do I say all this? Well, because I think if there is going to be a move to including philosophy and specifically phenomenology, which is a much harder sell to a lot of clinician scientists, you've really got to justify where philosophy has its place in the undergraduate curriculum. And I think people often make the assumption that they have to demonstrate benefit somehow. And with an education academic hat on, I think that's really, really difficult because if you're looking to show how people's practice is affected over the trajectory of their entire career, There are so many confounders that are going to affect that. It's going to be very, very difficult to prove. And what metric would you choose? Do you use sort of surrogates for empathy, which you see used a lot? Is it performance in postgraduate examinations? I think that's really difficult. So I think we should focus in communicating this and communicating why we think it's important on the future challenges. And in those, what does the future of medicine look like? So this was a paper, review paper written in Nature Medicine. I'd also like to take a moment to look at this image that was from that paper of the pink backgrounded, doe-eyed woman with her mouth agape being fed numbers and a key that goes directly into her head. Let's just pop that one to one side. But anyway, moving on from the image, they asked a group of very influential and famous doctors what they thought the future of medicine was going to be. And they, I think, maybe predictably in this setting, said AI, genome-wide association studies, precision medicines, CAR-T. Jeremy Farrar said changing research culture, which is interesting, and the global health agenda. So making sure specifically that from the African Union that people make their agenda the Agenda 2063. But we often think about how do we teach doctors to become clinician scientists of the future, but we talk far less about what it's going to be like for your average doctor to practice in this imagined future. And I say that future of medicine because this is ultimately just speculative fiction when we write new curricula. We're imagining what a future might look like. So coming in a very circuitous route round back to phenomenology, that's where I think we should start. To me, the big issues that are going to be the skills that we need to give our new doctors are around evidence and causation. You read a lot of things about coding for medics. It's really useful if you're a researcher doing quantitative work to know how to use Python or R. But it's a kind of hangover from EBM that we assume that doctors are able to weigh up evidence and causation if they can read a paper, they know about Frequentis stats. That seems to me to be extremely obvious if you're working with novel decision aids or you're working with machine learning. And just as we had on the previous slide, the things that people are predicting will be the challenges or the promise of the future, what are the things that aren't on that slide? And to me, the most enormous one is what's called medically unexplained symptoms, a phrase I absolutely hate, but currently unexplained symptoms. And if the reference there is from the British Journal of General Practice, really quite a controversial editorial, but suggesting that 45 to 50% of primary care appointments are about symptoms that are currently unexplained. And how on earth can we project a future where half of the people who are arriving at primary care are considered to have illnesses that are simply unexplained, which seems extremely peculiar to me to be looking into a quantitative AI-driven future. So who in our academic community, who in our world community knows about evidence and causation and thinks deeply about these things, and who thinks about definitions of disease and understanding the structure of experience? And I'd say this is the way in, this is the argument for, now I'm certainly not a philosopher, I have no training at all, but I've been very lucky to speak and collaborate with philosophers. Well, to me, this seems to be the community of people who think very deeply and communicate with terrific clarity on these topics. So how do we get to the next stage? Well, I'd say let's look at current practice. So the phenomenologists will be delighted that I'm finally dragging the topic of conversation around to what was advertised. I was very lucky, and I went to North America to see how narrative medicine and how philosophy of medicine are taught in a couple of centres. And one of the techniques I saw was of people using close reading of fiction texts, but also taking really quite what would be considered here challenging philosophical texts and using them as starting points for discussions with undergraduate students. And in my own teaching practice, I have found Javi Corral's Phenomenology of Illness to be a transformative text in teaching, especially chapter 5. It's also a wonderful way to address epistemic injustice. And if we're talking about unexplained symptoms, getting students to think about the role of testimony as well, and to think about where evidence comes from, not just as a settled story that we often tell in medical education, that things are contested and they're to be examined properly, and the knower is as important in some circumstances as the knowledge that they share and impart. And then in my own work, I found that doing qualitative research, I have slowly moved towards using phenomenologically informed methods. And this might be the bit that people think isn't phenomenology, and I'm actually really comfortable with that. It isn't. This is what I'm about to describe is qualitative research, pure and simple. I am not presenting any arguments that would be considered pure philosophy. What I hope it is phenomenologically sensitive, and I would be very, very interested for any feedback that anyone has to share about what they think any further directions could be in this. So what do we have? So one of the questions that has bothered me for a very long time is about how we develop expert surgical practice. So these two pictures, the left-hand side is a very grainy picture of Miller's Review of Orthopedics, which is one of the most breathtakingly dull books in existence, which is the handbook that you pretty much have to memorize. It's enormous, it's a big doorstop, and it's the book you memorize to pass the fellowship of the Royal College of Surgeons. Now, the simple fact is, if I were to read Miller's and I were to memorize it, and even to pass the written exams, there's no way that really substitutes. I don't think there would be much debate about this, that you would be able to read Miller's and walk into an operating theatre and be able to do a wrist replacement, which is what the picture shows. So that's me with my boss on fellowship. So what is there? What is the difference when we have experiential learning in the operating theatre? What are we actually sharing? What's going on in the operating theatre? And I'm certainly not the only person to ask this. There are lots of approaches and lots of thoughts about it. And the thing that struck me is that at the beginning, we imagine that operations are steps. So Miller's will say, make an incision, check for superficial nerves, find this bone and take it out, suture the muscle cuff. These are instructions. These are actions to be carried out. But the interesting bit is the judgments that are made. So I would suggest that operations aren't just steps. The tricky bit is knowing that you finished a step and making judgments about the world as you go. So making an incision is about knowing how hard you have to press with the scalpel. Checking for nerves is actually about knowing and being completely sure. It's about sort of confidence, about knowing that you've protected every nerve. Fragmenting a bone and removing it is making sure it's all gone. And suturing a muscle cuff, so sort of like a folded over bit of muscle, is actually it's partly knowing how to throw the stitches. There's something about a sort of practical skill in there, but it's also about gathering something about the texture of the muscle to make sure that it can take the suturing material. And that is something which is purely situated in one place. No two muscles are the same. And that time and place situatedness is somehow very, very important. So the next sort of, that is literally, this picture is the only time I will be in nature. But this was a workshop that we ran called The Art of Performing Science. And it was actually more about, it was run by my supervisor, Roger Kneebone at Imperial. And it was more about getting basic scientists together and seeing if there was a sort of any correspondences between the actions carried out by scientists and clinicians, artists and makers. But in this particular example, we realised that Phil, who sat next to me, is a letter cutter. And his sense of confidence and judgment and using all his senses as he carved was something that we shared really quite closely. So he would, when you put a hip replacement in, you hammer the hip replacement home. And the problem is the implant can shatter the bone. So you have to listen to the tone change as it goes down. So it'll go ding, 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 ding. I can make the noise, but I can't really express what it feels like to feel the vibration in my hand and to make the judgments about how hard I have to push it. And similarly, Phil has a really similar embodied sense about, it's unwritten, it's difficult to describe, but he can describe the texture of stone as he carves. So we were a little curious to see whether there might be something similar in there. So I went out to the literature. This is 2018. And I had absolutely no idea of this literature whatsoever. But I knew that I was curious about expert practice, and I knew I was curious about physical practices. So thinking of surgery as a craft rather than the usual accounts of expertise as decision-making, these kind of quite bloodless studies where surgeons put into laboratory technicians and their finger movements are measured. I was much more interested in situated practical experience in the operating theatre. And I was really, I suppose, back one, from being in the US, I'd encountered Merleau-Ponty, and I'd joined a half semester of phenomenology, and then I suppose I was sort of maybe predisposed to this. But then I was really taken with phenomenologically informed study of expert practice, and that's where this started to change the direction of how the rest of the study went. And two particularly really striking researchers whose work I really enjoy are Tizana Raven and Simon Hufting. I really enjoy their work. And then at the same time, while I was writing up, there was this an interesting move in the medical qualitative literature, re-exploring what phenomenology actually means to qualitative researchers. There was a lot going on in that in the environment. So what do we do? This is a picture of field work. It makes me quite nostalgic. I want to be out doing field work at the moment. So this is a workshop we ran at the what's it called? City and Guilds Art School of London. They let us into their carving studio. You can see Zaid, who's there in the centre, who's given permission for his name and image to be used. That's Zaid showing how he would make a break in a mandible. He's a children's head and neck cancer surgeon. And this is also the time to thank the IP, where I have an honorary position as a research fellow in the Arts Humanities Research Council, who funded some of the write-up and the support for the next workshop. So thank you to them. What do we do? Well, the question at the heart of it in terms of developing expert practice, I was curious about absorption and attention. Anecdotally, surgeons do talk about flow, but it's not really very well described. And again, as we said before, I was interested in how surgeons and sculptors make judgments during their practice. The workshops and interviews, one long workshop, and then separate interviews with surgeons and makers. And then a turn back to my usual practice in qualitative research. I just undertook a straightforward thematic analysis, just as Brawl and Clark would do, as described in the psychological literature. So what did we find? Now, I have discussed this with a lot of people, and they often find this not especially phenomenological, and I'm sensitive and open to the fact that a lot of the themes that were constructed through this do not really give any great insights as to the invariant structure of experience. I found it really challenging, but I think we have areas that we can go to from what was found. So what were the big four themes that were constructed? There's a huge body of unwritten knowledge, whether people chose to describe this as tacit knowledge, they called it embodied knowledge themselves. They knew that it was difficult to teach, and they often had to use gesture to explain fully what they were doing, especially when the experts were describing between themselves in the workshop setting. All of the experts, the surgeons, the carvers, the makers, had a sense of altered attention, so that they would sometimes be very much in the room with their practice and at other times very far away, and that unexpected things that happened would pull them suddenly into a sense of where they were. And the relationship with their tools was very much mediated by that as well. Well, they thought it was mediated. They thought their relationship with their tools was altered by the change in their attention, but they couldn't really describe it. So I suddenly felt it in my hand. I knew I had the wrong thing. But they never wanted to talk about the tools themselves, which was really peculiar. They did use their tools to sense, and they also had a very strong aesthetic sense of good work was pleasurable. So it's not just that the doing, the making was nice, that the item was nice, the act of doing something that was good. Good carving sounds beautiful. Good surgery feels, good tissue feels nice under the thumb. The sensory experience of touching it is nice. And they also had these very, very stereotyped ways to represent the world. that they described as mental representations, but I'm not sure. Theme 4, I'm never really sure about whether I have added that myself, whether in fact I led them to make some of these representations, but we'll get there. I'm not going to make you endure all of the comments of the wonderful participants, to whom I'm really grateful. But here are some choice, interesting thoughts of theirs about judgment. So what I did was I tried to use, especially in the interviews, an elicitation interview, and trying to sort of bring them back again to a very particular situated time and space. So it's a sort of iterative, and how did you do that? Bringing them back to a moment in their practice. Obviously, I didn't, in the field work, I was just watching, but here we've got one of the carvers discussing how she knows that something's shaped the right size. I'm like, well, I can fit my thumb in there. My thumb fits really nicely in there. I've always enjoyed this. Where are we? And then when I come to your carving, it doesn't, well, not like words like that. She simply can't describe what she's feeling, but she has a sense that feeling something with her thumb and her index finger is a trick that she knows, but the sense of snugness, she describes snug a lot, and snugness is a particular quality about the work, so she knows that something fits. One of the surgeons, S1, how do you find the place where you need to fix? So I was trying to bring him back again and again to the feeling and the experience of fixing a mandible, fixing the jawbone, where you can't see where you are, you do it by feel. And the only way he could describe it was you go to where there is nothing and come back to where there is something. So he's got a sense of ordering and of nothingness beyond it. It's very peculiar. He came back to this over and over again. This is a really strong, this is expressing something very strong to him about the feeling of, I could see that I'm now falling into the hole of introspection and I'm trying to guess what he's thinking. And that's the temptation in work like this. No one could talk about confidence. They just joked about it. It was amazing. They did not want to talk about confidence. I couldn't get anyone to talk about confidence. And then attention. So it really varied. So this surgeon in particular had no sense, really. He really had this extraordinary focus all the way through, and very active, conscious checking. Now, again, I'm not sure I ever got there with him. I think that could be a researcher-interviewer problem rather than anything else. And then the carvers found it much more easy to talk about euphoria and about a sense. So this is C1 again. I think also if you've done it for a while, you know how your body physically feels when you're in that euphoric moment of it all going really well. You just know from the outside what you look like. And you're comfortable, you're relaxed. And I think you recognize that in other people. There's pleasure. The surgeon knows that here we've got, you can use your finger or suction to complete, lost my mouse, to complete here very gently. It's quite beautiful, I think. It's lovely to do, lovely feeling, because you just know what you're doing. You can hear the texture of tissue you can't see and respond. The carvers could also tell how their students were doing in the next room, and C1 again describes listening to the sound of her students and feeling that the sound is sublime when they're carving well, when you can hear the senior students carving. And she describes the practice of another carver, C2, as having a musical quality, that people actually come and listen to him because it's so pleasant to listen to him carve. Reflecting on the technique, and I think this is where I have taken a lot of very, very relevant and pertinent and important criticism on this. It's really challenging for clinicians, and I'm not convinced in many places that I haven't fallen into a hole of tending to introspection, to possibly cataloguing phenomenality, or trying to overinterpret or explain things that are more about my construction of what was going on. Interestingly, a tip for anyone who thinks they might like to use these methods, the people that I had the longest contact hours with were far, far easier to use this method. Definitely the best interactions, and definitely in terms that we both in I think I developed an expertise in the interviewing style. It was much, much easier. And by that, I mean, sort of at around the 15-hour mark, we started to really, really fly. And getting them to that particular episode, the elicitation was key. The best insights definitely came from actually, weirdly, some of the almost offhand things that people said, but being able to bring them back to a particular moment in their practice. How are we doing for time? The findings, what do I stand by? Well, I do stand by the descriptions of attention and absorption. I think there are differences that the sculptors and surgeons described. The carvers were much more able to access moments of complete absorption and moments of elation. They were fleeting for surgeons. And I think that there is something interesting for people interested in the development of surgical practice to think about focus and attention and why that might be, and the effect of coming in and out of states of attention. The thing I didn't expect was to have such a fine-grained description of the sensory experience of being in theatre. It just exploded. People had so much to say about it, and certainly there are lots of fabulous sensory ethnographies in medicine, but they are often talking about technological mediation, so work about auscultation, about sound, about sensing hospital experiences. I don't think I've cut, but I would love to hear if someone knows of one, but I've not come across something that has looked at surgical practice as craft in this particular way, but I would love to hear more if anyone does know. Honestly, I think despite using phenomenologically informed methods, I don't think I have advanced our understanding, truthfully, an understanding of the structure of experience of these experts. And I don't know whether what I'm thinking about now, and we're thinking about as a wider research team, is whether this is something that would just be more contact hours and more time and we'd be able to improve. And as to whether there are relevant research questions out there that will be served by those methods. But what we have found is a pleasure in the sensory experience of practice, and that is something that has already affected training. So we've already fed that in, to start to look at, especially while in COVID times been offline and doing training, seeing whether we can get trainees to talk about that sensory experience and how they find pleasure in it. So that's heartening. The next steps for us is we're considering a taxonomy of craft practice. So finding these instances of expert practice, such as manipulating fine tools, tuning a machine, and talking about sort of knowing when something is just right, and really understanding a bit more about how we make judgments based on physical experience, sort of situated judgments. I suppose to sum up, all of this has been presented and written from the perspective of a clinician educator. I hope it is taken in that spirit, and I hope that there are bits that people can take in their own practice that might be something they didn't expect, especially people who might be in their home institutions trying to talk about how to get philosophy into the undergraduate curriculum and what some of the ways to approach a curriculum review board. I hope the first half might help in that. I strongly feel that, I can't overstate it, my opinion, that causation and evidence and experience and accounts of illness and disease are utterly under-examined in the undergraduate curriculum. This has to be fixed. And I hope that people have found it interesting to see what I hope phenomenologically sensitive and interesting study into surgical practice might look like, and how academics in medical education are starting to use these methods as well. So thank you very much for listening. That's me.